Hello everyone, my name is Alexa Mogus, and in this presentation we are going to talk about the bacterial disease meningococcal meningitis. So meningococcal disease is recognized as a worldwide public health problem due to its distribution, potential to cause outbreaks or epidemics, its impact on children and adults, high mortality rates, and significant morbidity represented by complications of this disease, especially permanent neurological damage. In this slide, let's review our objectives for this presentation. So we are going to discuss the bacterial disease meningococcal meningitis, specifically the organism that causes this disease. We will review the bacterium's scientific name, taxonomy, morphology or structure, and the scientist who first discovered it. We will also address its pathogenesis, how does it cause infection, the signs and symptoms that the body may present, how this disease is diagnosed, its epidemiology, so where it is prevalent and how does it spread, and lastly, treatment and prevention options. Meningococcal meningitis is a rare but serious infection caused by the bacterium Neisseria meningitidis. N. meningitis can be classified into 12 serogroups based on its capsular polysaccharides surrounding the bacterium. Serogroups A, B, C, W135, X, and Y are the primary causes of meningococcal disease worldwide. The most frequent presentation of meningococcal disease is meningitis, and this is where meningococcus crosses the blood-brain barrier and proliferates in the cerebrospinal fluid. Bacterial meningitis is characterized by inflammation in the tissues, or our meninges, that surround the brain and the spinal cord. So these three important tissues would be our dura mater, arachnoid matter, and our pia mater. And then if we take a look on the image here on the screen, we can see an overview of a healthy brain, skin, and skull where the meninges are normal, and then we can see to the right what would happen if we had meningitis, and it shows our inflamed meninges. And then also on the bottom left here, I do have an overview of where the dura, arachnoid, and pia maters are in the order they go between the skull and the brain. Okay, so let's review taxonomy. So taxonomy is a methodology that involves systematically classifying elements in a defined hierarchical form. Taxonomy entails the description, naming, and classification of living things. So let's take a look at the bacteria N. meningitidis, and please bear with me with these upcoming names. So this bacteria is part of the domain Bacteria and kingdom Bacteria. The phylum is Proteobacteria, and Proteobacteria are currently the largest phylum within the bacteria domain. Proteobacteria is a major phylum of gram-negative bacteria. N. meningitidis is part of the class Beta-Proteobacteria. This class consists of several groups of aerobic or facultative bacteria that are highly versatile in their degradation capacities. The order Necessarius is comprised of gram-negative non-sporulating bacteria. N. meningitidis is a member of the family Neisseria, which are gram-negative coccoid-shaped bacteria that lack flagella and possess an outer capsule. And then finally, we've got the genus Neisseria and species Meningitidis. In this slide, let's review the history of N. meningitidis. So this bacteria was first discovered in 1887 by an Austrian pathologist and bacteriologist, Anton Wieselbaum. He first identified a Diplococcus intracellularis meningitidis from the cerebral spinal fluid of a patient infected with meningitis. This organism was reclassified as a member of the genus Necessaria after the German physician Albert Neisser discovered the Diplococcus known as Neisseria gonorrhoeae in 1879. Italian physicians and zoologists Ettore Marchifava and Angel Celli described the presence of oval micrococci within leukocytes in the cerebral spinal fluid of patients dying with meningitis in 1884. By 1896, German physicians and microbiologists Johann Hubner and F. Kiefer were the first to isolate meningococci from the cerebral spinal fluid and throat of living patients. In this slide, we are going to review the morphology of this bacteria. So N. meningitidis are gram-negative cocci grouped in pairs or diplococcus, with typical morphology being or kidney-shaped, with humans as their sole natural host. Surprisingly, up to 10% of the general population carries this bacteria in their nose and throat without any adverse effects. These bacteria neither form spores nor possess flagella, but they have fimbria or pili. They are aerobic agents, catalase positive, oxidizing glucose and maltose with acid production and without gas formation. This bacteria grows well in both chocolate and blood agar at temperatures between 35 degrees Celsius and 37 degrees Celsius. So let's take a look at the figure here on the screen. So part A, we have a scanning electron micrograph of the 3 meningococci of the surface of the human endothelial cell. And this shows a diplococcus shape of the bacteria. In part B, N. meningitidis is a diderm bacterium. It possesses 2 membranes separated by a periplasmic space containing peptidoglycan. It typically expresses type 4 pili in a polysaccharide capsule. And also on the screen here to the top right, I have a blood agar plate. And then on the bottom of that blood agar plate, I have a gram stain of the bacteria as well. Okay, so let's review the pathogenesis of this bacteria. So a case of meningococcal meningitis typically begins with a throat infection leading to bacteremia and eventually meningitis. N. meningitidis is transmitted through respiratory droplets of infected people or from asymptomatic carriers. Specifically, transmission occurs by droplet aerosols or direct contact with secretions. The incubation period varies from 1 to 14 days. Person-to-person transmission is facilitated in confined environments, such as military camps, child care facilities, or college campuses. N. meningitidis is exclusively found in the human nasopharynx, where it mainly adheres to columnar epithelial cells. This bacterium can cause meningococcal meningitis by accessing the bloodstream. Once in the bloodstream, meningococci circumvent an immunological response by several virulence factors. So we're going to go over those. There are 5. So first off, the polysaccharide capsule. This is a structure that protects the etiologic agent from complement-mediated phagocytosis and lysis. It is important for the differentiation of the serogroups. Lipopolysaccharide is an endotoxin because it presents itself in the bacterial wall, and it is important to N. meningitidis and is responsible for toxic shock and meningococcal adhesion and activation of the innate immune system. Our adherence factor is our type 4 pilus that binds to the CD46 receptors. It is located on the external plasma membrane and plays an important role in pathogen adherence to epithelial and endothelial cells of humans. Our external membrane proteins belong to the porin class. They participate in adhesion and invasion of the host cell, which induces calcium influx and apoptosis of epithelial and phagocytic cells, in addition to activating toll-like 2 receptors. Our iron incorporation, so with reduced iron, the bacteria expresses proteins present on its external membrane that capture iron from lactoferrin and transferrin and internalize it. And then as we can see here on the screen, our image just shows where our bacteria presents itself in the nasopharynx and then how it travels down, where it adheres, proliferates, it detaches, and it invades. Okay, let's talk about epidemiology. So, meningococcal infections occur worldwide but display different epidemiologic profiles in different parts of the world. In most countries of Europe, North America, Southeast Asia, and Western Pacific region, since the introduction of antibiotics, the disease has become rare. In Africa, meningococcal disease presents mainly as an epidemic or even pandemic outbreaks, with incident rates up to 1,000 cases per 100,000 individuals. It is particularly pronounced in countries of the sub-Saharan region. This area is called the meningitis belt, and this is the highest incidence of disease found. Local outbreaks are facilitated by modern ease of travel, which exposes populations to different serotypes that are otherwise uncommon in the area. The incidence in industrialized countries is sporadic and varies by age, occurring most often in infants who have not yet developed protective antibodies. In arid regions of Africa and Asia, dry air causes the nasal mucous membranes to become less resistant to bacterial invasion, contributing to the widespread epidemics of serotype A and C, and to a lesser extent to serotype W135. The 3 meningococcal serogroups that most commonly circulate and cause disease in the United States are B, C, and Y. In the picture of the map I have here on the screen just identifies what serotypes are found in what countries, and also shows incidence in the 1900s of cases in specific countries or states. Okay, so what are our signs and symptoms? So initial presentation of N. meningitis caused by meningitis may include sudden onset fever, headache, nausea, vomiting, severe myalgias, nonspecific rash, a sore throat, and other respiratory symptoms. Later presentation of the meningococcal disease includes neck stiffness, photophobia, petechiae, which is hemorrhagic rash, altered mental status, shock, abnormal skin colors, and purpura fulminans. Purpura fulminans begins with dermal microvessels thrombosis that rapidly leads to hemorrhagic skin necrosis. Target populations of meningococcal disease include infants, teenagers, young adults, individuals suffering from sickle cell disease or are immunocompromised. Okay, so how is meningococcal disease diagnosed? So this disease can be very difficult to diagnose because the signs and symptoms resemble those of other illnesses such as the flu. A lumbar puncture is a diagnostic tool of choice for the identification of meningitis or a spinal tap. CT imaging may be indicated before a lumbar puncture to ensure no increased risk of herniation. Blood cultures and cerebral spinal fluid analysis should include a gram stain, culture, glucose, cell count, and protein count. Diagnosing meningococci can also include analyzing peripheral blood, skin lesions, synovial fluid, pleural fluid, or pericardial fluid in patients suspected of having pneumonia, septic arthritis, or pericarditis due to meningitis. Cerebral spinal fluid assays exist and include PSR, or polymerase chain reaction, and latex agglutination to confirm meningitis infection. In our last slide of this presentation, let's talk about treatment and preventative measures. So, effective antibiotics can immediately interrupt meningitis proliferation. The meningococci in the cerebral spinal fluid are killed within 3 to 4 hours of intravenous infusion of an adequate dose of an effective antibiotic. A third-generation cephalosporin, cefotaxime, or ceftriaxone should be given once the diagnosis is suspected. If the culture identifies the organism as penicillin susceptible, treatment can be switched to penicillin G. The focus in treating meningococcal infection is antibiotics, isolation and contact precaution, infectious disease consultation, management in the intensive care unit, management of coagulopathies, and identifying those at risk who may have been infected. Deterrence and prevention of meningococcal meningitis can be achieved by immunoprophylaxis or chemoprophylaxis. Antimicrobials commonly used to eradicate meningococci from the nasopharynx are rifampin, quinolones, and ceftriaxone. Vaccination is the best strategy to prevent disease, especially in at-risk populations. So there are 2 types of meningococcal vaccines that are available in the United States. The first one is MenACWY, and this is a combo vaccination indicated for active immunity against evasive disease caused by the serogroups A, C, Y, and W135. Serotype B vaccinations, there are 2. So the first one is Trumenba. This was approved by the FDA in 2014. And there is also Bexsero, which is another serogroup B vaccine that was approved in 2015. Both of these vaccines contain bacterial surface proteins and are recommended for 16 to 23-year-olds who are at risk of contracting disease during outbreaks. A rare serogroup called X that emerged in the sub-Saharan Africa during the 2000s does not have an available vaccine. And these are my sources that I used to create this presentation. Thanks for watching.